I'm going to talk on strabismus surgeries, which is actually a very complex topic, but I would like to make it as simple and as interesting as possible for the postgraduate students. So before we embark on strabismus surgery, we need to look at certain other requirements. You need to treat the refractive error, correct the amblyopia if it is present, do orthoptic exercises if possible, and then embark on your surgery. The goals of the surgery has to be clearly explained to the patient, and the importance of follow-up also has to be emphasized, especially if it's a small child. Now, the indication for strabismus surgery is basically to provide alignment. Alignment means both eyes will have the same visual direction and they look at the object of regard. And with alignment, we can also improve the binocular single vision, which means you're providing stereopsis to the patient. You can also improve extraocular motility in certain cases and increase the field of vision. Now, this is three cases I would like to illustrate. This is a small child with infantile esotropia. This child is perfectly aligned, but the sensory result is a microtropia with peripheral fusion and cross stereopsis. This young lady with IDS had good pre-existing stereo vision. So after surgery, apart from alignment, we are retaining the stereo vision and central fusion. Now, this particular child had an MED, and as you can see, there is an elevation deficit. So post-surgery, we are also improving the extraocular motility. The elevation is improved. Apart from giving a good central alignment, we are also increasing the motility and field of vision. So these would be the gross indication of surgery. Before you embark on surgery, look at the position of the patient. This is very important. The neck has to be extended, and then only you have a good exposure of both eyes. And you need to have a fine set of strabismus instruments. But I would emphasize on the various beautiful hooks that is available for the strabismus surgeon. This is the smallest one, is the Stevens stenotomy hook. Then you have the Von Graffi smooth hook, the Chavez hook, the Helveston hook, and the Green's hook. And of course, there is another hook called also as the Jameson's hook. So you need to have this entire armamentarium of instruments with you. And also, I would like to teach the beginners on certain anatomical landmarks. The limbus is one important landmark. Limbus is the point where you have the fusion of the conjunctiva, the Tenon's capsule, and the intermuscular septum. So when you make a limbal incision, what happens is you directly enter into the subtenon space, and it's very easy to hook the muscle. The other thing you have to pay heed to is these two pads of fat, the extraconal pads of fat at the fornices. And you can look at the superficial conjunctival vessels and the deeper anterior ciliary vessels. Now, the next particular slide is the FORNIX incision. Now, when you do a FORNIX incision, you have to open up the conjunctiva separately. You have to open up the Tenon's capsule separately. And then you can place your muzzle or your Jameson's hook. And this tissue which you see here, where the muzzle hook is indenting, is the intermuscular septum. And you can see these beautiful anterior ciliary vessels, which are causing for the muzzle and going anterior to the muzzle insertion. Now, the dosing of the surgery, the medial rectus muzzle anywhere between 3 to 7 mm. Lateral rectus is a little larger, 4 to 10 mm. The superior and inferior rectus is 3 to 6 mm. And you don't do more dosage for this vertical recti because you know they are attached to the lid retractors and they can produce changes on your lid position. But there are, of course, exceptions, especially when you operate on a patient with DVD or tight muzzles. And R&R always will have an augmented effect. It's about 25 to 30% more augmentation. And when you operate on smaller or pediatric eyes, your dosages have to be also lesser. Now, adjustable versus fixed, all beginners should start with fixed sutures. Unpredictable results go for adjustable sutures, and they are seen in paretic muscles, restrictive strabismus, myopathies, and resurgence. Weakening procedures on the muscles are recessions and the FADEN operation. Strengthening, of course, is resection, advancement, and plication. The first surgery which I'm going to show you is an adjustable surgery on a limbal flap. This is the noose. So you're creating a limbal flap, which is easy to create. You hook the muzzle. You dissect it free of its attachment. It has to be smooth and shiny in its muzzle capsule as seen here. You're cutting the intermuscular septum. There is a 3-point fixation of the muzzle, the first central fixation bite and the 2 locking bites at either edges. So the first surgery I'll show you detail. The rest I will just show you the important parts of the surgery. There's a lot of surgical videos. So this is the 3-point fixation, and at the edges you take locking bites. You disinsert the muzzle. After disinsertion, you're going to cauterize the stump. Gentle cautery, there's no need to do a heavy cautery. And then since this is an adjustable noose suture, I mark the center of the muzzle stump and I will take the crossword technique. So you will be taking 2 blights in this sclera very close to each other in a crossword fashion. The muzzle is going to hang behind. So this is called as the hand back. You create a noose on this suture. So you create a noose here, and this noose is adjustable. You can move this noose up and down. Suppose you want to recess more post-operatively, you can move the noose forward or backwards. A noose is created. And you can see just in a moment how it can be moved up and down. See, you can, and then I will hang the muzzle. See, I'm measuring the amount of recession. So I will be hanging the muzzle backwards. And then I will close up the limbal flap. If you're afraid of creep, you can place belt sutures close to the muzzle here. Superficial belt sutures. Okay. So then the limbal flap will be closed up. So I'm not showing that. I'll move to the next video. The next is plication. The first video was a recession. Recession is you make the muzzle lax, so you weaken the muzzle. Plication, you make the muzzle taut. I will go a little forward. Yeah. So in this plication, what I want to show is the muzzle is formed like a hump. So I'll go here. See, after taking these bites, I'll go a little faster. Yeah. So you go anterior to this thing, insertion of the muzzle, and you will hump it. Now, I don't do this. I do Dr. Sharma's technique, which is the modified plication or reinforced plication, because I don't want this a little unsightly hump to be formed. So I go to the next video. Again, I put it on noose adjustable. I do adjustables all the time. So you can do the fixed suture also. This is the reinforced plication. I'll go to the part where this is a small plication. So again, you will, the amount of measurement, you place the suture on the muzzle. So want of time, I just go a little forward. Yeah. So you take the bites anterior to the insertion of the muzzle and you come back into the muzzle. And it will fold over. It will neatly fold over. See, the muzzle is folded. And now I put the adjustable noose here. So even the resected muzzles are put on a noose. The recessed muzzle is also put on a noose. I don't adjust, but I always do it as a methodology which I am tuned to doing, so that if I want to adjust, I can always adjust. Now, this is the reinforced plication. Now I'm showing you the FORNIX incision. The FORNIX incision is done at the infratemporal fornix. Let me show you. I've disinserted the muzzle. It's a little cumbersome because, and then this is almost like a fixed suture, but what I'm doing is I'm placing it on a bow tie. Now, just to show you how a bow tie is done. But you can do a square knot and you can fix it also. No harm. Once this bow tie is done, you'll close up the incision. So this needs a little maneuverability. I'm not going into the detail of the FORNIX surgery. And then you close up. So on the other side, we will show the resection. So on the other side, I mark this amount of resection. You do a 3-point here. Okay, this is again a FORNIX incision. So once you do that, I will disinsert the muzzle. because I'm showing all the surgeries, I'm a little bit fast forwarding, otherwise the time won't be enough, I'm sure about it. I will disinsert the muzzle. This is the amount of resection where I'll cut off this portion of the muzzle. Thereby, you're shortening the muzzle and making the muzzle taut. Now, at the stump, I will be taking the bites and I'll be coming back into the muzzle. Okay, so I'll be coming back into the muzzle and then I will be tethering the muzzle at the insertion. So the excess of muzzle stump will be now cut. So once I will come on either end, I will tie it down. Again, this is done on a noose because if you want to recess that resected muzzle a little bit post-operatively, if you want to adjust, the noose will help you. And then I will cut off the stump. So this is how I will do. Then I will close the flap. I'll go on to the next surgery, which is FADEN operation. FADEN is when you want to increase your recession effect, you will do a posterior fixation. This is my technique, which is published in the IGO. After doing the 3-point fixation with the non-absorbable suture, you take 2 bites, one at the recession site and one at the posterior fixation site. Now I have done about 7 mm of recession and 12 mm is the posterior fixation. I'll come back into the muzzle at the recession site. Then I will disinsert the muzzle. I'm disinserting the muzzle. And you can see that I have, I'm tightening the posterior fixation suture site. And you can see that it is recessed by 7 mm and the posterior fixation thing is around 12 mm. So you increase the arc of contact, you reduce the momentum, thereby there is more recession effect and decrease action of muzzle in the field of action of the muzzle. So we'll go to the last thing, which is inferior oblique recession. So again, I'm going to show you. Now I'll start here. I will reduce my, this is got this thing. This oblique muscle close to the lateral rectus. I will reduce this voice. With this, I have, since it's a very lax tendon, I've removed part of the tendon before placing it at the inferior rectus recession. You can do that because you want to augment the weakening effect further. Otherwise, you can place the entire stump also at that point. So I mark it at the inferior rectus and then I will place it. This is again placed on the noose. And then I go forward and I do the lateral rectus recession on this patient. Once the recession is over, I will close up the conjunctiva. You can just see how small this site of incision of the muzzle is. So finally, I'll be just showing you, I'll be closing up this FORNIX incision. So the lateral rectus incision is also over. Inferior oblique, anterior transposition and lateral rectus recession is over. Both have been placed on adjustable noose and I'll be closing up this. So you can see once I've closed up, it's such a small incision. I'll remove the thing and I will show you. When I remove the, see, it is just under the lid. You are operated upon. In case of SO palsy, so the last side, the commonest muscle that you operate upon is your horizontal recti. It corrects your horizontal deviation. It also corrects some amount of small vertical deviation when you shift the muzzle up or down. You can correct your A and B patterns by bringing your medial and the lateral recti, the medial recti towards the close end of the pattern and the lateral recti towards the open end of the pattern. Paratic spins can be well corrected by transposing either your horizontal or your vertical recti to other muscles. And inferior oblique procedures are the common oblique muscles that are operated upon The procedures that we do are recession and anterior transposition. Superior oblique, I'm not covered for want of time, but you can always look up videos. Beautiful videos are there in YouTube. Thank you very much for your patient listening, and I hope I could convey the points needed for postgraduate students.
Thank you, Dr. Manjula. You have really covered most of these surgical procedures which are commonly done in a very small time capsule. So really, that's worth congratulations. And you have highlighted the point that we can adjust the muscles and we should be trying to align the eyes. It's not just important to do a surgery, and especially when you're talking of children, it's not just early surgery, but early alignment which makes the difference in restoring binocular vision.
Definitely.
So for that, we have to be either, even if we don't do adjustables, we can restore binocular vision with the help of other procedures like maybe prisms, or by adjusting the spherical correction in children if you can't do adjustables. And you have also highlighted that inferior obliques are better recessed and anterior positions rather than doing myectomies, which are non-adjustable and which are like more traumatic procedures and you can't undo it. So